Welcome to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. Using telemedicine, a group of volunteer Mayo Clinic physicians in critical care medicine are providing support to a community hospital in New York City where they have been inundated with COVID-19 cases. The telemedicine ICU program is underway in participation with York-Presbyterian Lawrence Hospital. And here to tell us more about this is Dr. Caples, the organizer of this effort and a Mayo Clinic pulmonary and critical care physician. Welcome, Dr. Caples.
Thanks so much.
It's wonderful to have you here. Can you tell us a little bit about the relationship that we formed with the ICU in New York and how that works?
Yeah, sure. So, the story goes back a number of weeks, maybe even a month or two. All of us were seeing the reports coming out of New York on the news. And, professionally, we could relate to what it feels like to get overrun on any given day. But this was such an exponential increase in patient care activities that we felt like we wanted to help. We had some bandwidth to help because we were preparing for the COVID rush that was anticipated to come here to Rochester. And so we felt like we were ready. People wanted to help. The initial request from many of the staff members, including fellows, was to actually physically go to New York and help out on the ground. And after everybody paused and thought about that, the risk is high. And so that really wasn't an option. And so there was a real appetite to help, and we didn't know how to do it at the time. And then there were a lot of connections being made personally between colleagues in New York and staff here in Rochester. A lot of our staff either trained in New York or have friends that work in New York. And so there were some personal calls that came through to see if there was a way that we could leverage our staff physicians to help. One that came through on a weekend was whether we could set up something through telemedicine. And so that was really the seed that started this, a personal connection.
That's great. It's a small world, isn't it?
It sure is.
Could you tell us a little bit about how the process worked to set up the electronic connections and the credentialing and licensing that were necessary for the physicians?
It was really an incredible team effort, both on our end and with the folks in New York. So typically, and we've been running the Tele-ICU program for 7 or 8 years now, and typically to ramp up, make a connection, and launch takes anywhere from 6 to 9 months. And so we knew that it wasn't going to be what we were used to, and we weren't even sure we could pull it off in a timely way that would still be helpful for the folks in New York. But, on that Monday, we got our team together, our information technology specialists, our operations team, sent a call out to the physicians, working with a really crackerjack group at New York-Presbyterian. We were able in 3 or 4 days to be able to make the connection, credentialing and licensing. We had an enormous response from the physician staff. 50, 60, 70 people volunteered to help. So just an overwhelming response. And by this past Saturday, we launched in the morning and we began rounding in New York.
It's really neat. Can you tell us a little bit about the physician staff, the members at Mayo who are helping out?
Yeah.
And how the timing of it all works?
Like I say, within a day of sending the call for help email, we had just an amazing response. And the way we're modeling this, we didn't really know what to expect because we weren't able to develop workflows like we normally would. And so we just decided we were going to go in there on a Saturday and join the morning rounds. Really, it's any of our intensive care specialists, our senior fellow, pulmonary critical care and anesthesia fellows. It's about a 3-hour round. We learn about the patients, we interact with the provider team, we interact with the patients, other members of the care team, and we just provide our expertise and input that we're used to providing every day at the bedside. And so far it's been a really great experience. I think we've brought value. I think folks in New York see the value, and we're all doing this to help our colleagues and to help the patients.
I know when I was training in residency, I really appreciated hearing how people at different hospitals did things. That when we'd have others rotate and I'd rotate elsewhere. So I can imagine that's a really gratifying experience.
Well, that's a point you bring up, is that they've seen exponentially more COVID patients than we have here in Rochester. So in terms of understanding the disease that COVID brings, we're learning from them. We can bring sort of the cultural piece of how an ICU operates from day to day, how the process flows, but we're really learning a ton about how these patients present, how they're able to manage the patients with COVID. So it's really a two-way learning street.
Many of us are familiar with the EICU services that Mayo provides. Is a Tele-ICU different in some way than an EICU?
No, it's the same. EICU is probably now an outdated moniker. I think the more traditional and now accepted term is TeleICU.
What exactly can you offer via telemedicine?
Yeah. So specifically for New York, I'll give you a little context. So what's happened is their usual intensive care unit has been completely overrun by the number of patients. And so what they've had to do was to set up another sort of ICU in an area of the hospital that typically is not an ICU area. So they took an ambulatory surgery unit and turned that into sort of a makeshift ICU, almost like a field hospital, so to speak. And because they only had a certain number of intensive care specialists who typically staff their smaller ICU on any given day, they've had to bring in physicians and advanced practice providers from other areas. So really what's happening in the unit that we're rounding in is it would be a cardiologist as the attending. It might be a fellow as the attending. It might be an internal medicine specialist or a hospitalist. And so what we're able to do is bring a little bit of the culture and process and know-how of critical care throughput, critical care processes, best practices, that sort of stuff that those attendings might not be familiar with. They've got a huge roster of docs who are able to round in the units, but they don't have that sort of ICU expertise that is needed to help move patients through the system. And so that's what we bring on rounds. We run checklists on every patient. We give input on medications. We can help them dose things for patients who are in renal failure. We make sure they get holidays from their sedation, for example. These are little things that we think of every day that aren't intuitive to somebody who doesn't do it on a regular basis.
As this pandemic has progressed, many of us in clinical practice have become much more familiar with telemedicine as far as offering visits into our patient's home using telemedicine, video visits, as well as phone visits. And I'm wondering, what other applications do you see, perhaps in the hospital or otherwise, for the use of telemedicine now and in the future?
You're right. And I'll tell you, having been doing this program for 7 or 8 years, it's very difficult to change culture. At Mayo, and I think at many places, we're so used to doing things in person and at the bedside, even though we've known for some time that telemedicine can bring a lot to patient care. And so this crisis has really shined a light on ways to do things differently. And so we've actually introduced a telemedicine program into our own medical ICU. We have the probably same InTouch tablets that you might be familiar with sort of the at-home care. These are tablets that are placed in patient rooms in our own intensive care unit that allow providers to communicate from outside the room. So for example, patients who are COVID positive or under investigation, you want to limit the amount of times you go in and out of the room. You want to limit the amount of PPE that providers are utilizing. So we've used these tablets with the InTouch application to communicate with the nurse in the room, to communicate with the patient in the room, also to communicate with family members who are still at home and unable to visit their loved ones.
And I imagine that it's just a matter of getting used to this somewhat. We have patients who haven't wanted really to see us on video visits, perhaps just because it's not something they're familiar with and would prefer to wait and come see us. But I think this pandemic may help us make some positive changes that way.
Yeah, I think so. Crisis breeds change. And I think rather than really having the option to do this, we just need to make it happen. and people can, it'll be a learning curve, but I think it's a lot easier than people anticipate.
Is there anything else that you'd like people to know, Dr. Caples, about telemedicine?
We're going to see a lot more of it once the dust settles from COVID, for sure. I think, as we're still in sort of the acute phase of the COVID pandemic, there still is a lot of bandwidth on our end to help wherever we can. And so we're trying to get the word out to maybe other institutions that could use us in a similar way. And so hopefully these kinds of media broadcasts can help do that.
Well, that's wonderful. Thank you so much for being with us today, Dr. Sean Caples, who's a critical care and pulmonary physician from the Mayo Clinic and is helping to organize telemedicine with colleagues in New York. Wonderful to hear about your mission and accomplishments today. Thank you so much.
Thanks, Dr. Gazelka.
Bye-bye.
Bye-bye.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. Thanks for listening, and be well. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu.